I'm delighted to welcome our speaker for the day, Dr. Laleh Seyyed-Kalantari. And Laleh is an associate scientist at the Lunenfeld Tannenbaum Research Institute in Toronto, in Canada. In the past, she has received her PhD in electrical engineering from McMaster University and was a postdoctoral fellow at the Vector Institute and the University of Toronto. Laleh's won a whole host of different awards, but I will point out that the latest one was the NSERC postdoctoral fellowship in Canada. And Laleh's research interests revolve around developing AI-based medical image diagnostic tools with novel contributions in theory as well as application, with a specific focus on fairness. Her ultimate goal is to remove barriers towards a trustworthy deployment of AI-based medical image diagnostic tools in the clinic. Today, she'll be sharing with us a wonderful article that she recently published, which talked about underdiagnosis bias of different AI-based algorithms. We're excited to have you here in the AIMI Journal Club, Laleh, and please take it away.
Thank you for your introduction, and thanks for the opportunity for having me here. Okay, my name is Laleh Seyyed-Kalantari, and here I want to talk about my recent work in underdiagnosis bias of AI-based medical image classifier for underserved patient population. Maya was a student. Unfortunately, she developed a medical condition which affected her ability to function. Initial assessment didn't show any diagnosis for her. Therefore, she sent home without further assessment. We currently have a lot of evidence of existing bias and unfairness in healthcare system. We have race and sex biases in disease underdiagnosis and also in risk score analysis tool that we are using in our healthcare system. For example, females are receiving longer time to diagnose compared to the male patient, even if they are having the same medical condition. Or the quality of care that delivered to a patient within the same hospital varies by the insurance type of the patient. Additionally, there are always some pre-assumption that some certain subpopulation may not develop some condition. For example, for young ages, they may not develop some specific cancer and things like that, which this pre-assumption also may help, may cause underdiagnosis for those patients. And all of these underdiagnoses can delay access to care for those patients. So let's see first what are AI diagnostic tools in medical imaging and why do we need them and what's their role in this problem. AI diagnostic tools are trained to yield diagnostic label from medical images. And you know that there are about 70 to 80% diagnostic problem that we can detect them and solve them using X-ray or ultrasound. And also, at the same time, we have kind of global radiologist shortage to interpret and review those results that coming from those scans. And this problem is kind of a global problem. And you can see if that's a problem in countries such as US, Japan, or UK, the problem is even more severe in some other countries that they may have one radiologist per 1 million or per 2 million population. So if we could use AI models kind of to interpret and read some of the exam results, we may help those patients to be able to diagnose correctly. And on the other side, even from those people who have access to radiologists, they are about 3.6 billion X-ray examination, just X-ray examination that we are doing globally in the world. And we know that from literature that there are about 3 to 5% diagnostic error in kind of reading those results and interpreting those results. A simple math will show us even only at X-ray examination, we have over 144 million diagnostic error per year. And if we could have AI beside doctors to just review the images and give us some second opinion, we may be able to reduce some of these diagnostic errors. That's why that we are looking for to get some aid from AI for developing AI diagnostic tools. So how do we train these models? The standard approach for training AI model is to train them on overall population and optimize them to have a high performance average across all population. And especially recently, we have had a lot of papers that they are showing their results, they are achieving high performance, and they are very good studies, and they are showing that they are even close to the radiologist's performance. So maybe that's a good sign that we may be able to like deploy this AI model in practice in hospitals and help those patients who don't have access to radiologists or reduce the diagnostic error. But if we look into the data set, the medical image data set, for example, here, I kind of aggregate the three largest public chest X-ray data set that we have, Mimic CXR, Checksford, and NIH data set, on 8 shared labels that these three data set have. And you can see the distribution of different diseases in this data set, which is very large data set. And as you can see, some diseases are very rare and some other are might be very common. And we don't have a uniform distribution around in our data set about the diseases that we have. And even if you look at your overall population, you will see the overall population that we are training, for example, in Mimic CXR dataset, is a mix of patients from different sexes, different ages, different races, and even from different insurance type. So we are wondering if all these patients, when we are optimizing these models to have a high performance average across all patients, all these patients that they are belonging to this data set have equality of opportunity in correct disease diagnosis, regardless of their membership to different subpopulation in the data set or not. So that's why it brings our attention to the fairness of AI model when we want to use them and develop them in medical imaging. But before that, like, what does it mean for an AI model to be fair? So there are many definitions that you can define for fairness of an AI model. And honestly, depends on the problem that you are solving, the data set that you have, the different attributes that you are gathering in your data set. You may define your fairness matrix very differently. But one of the well-known approaches for defining fairness is, for example, equality of opportunity notion of fairness, which is trying to equalize the correct positive outcome, true positive rate in different subpopulation. For example, in group 0 and in group 1, we want to have equal true positive rate. So when we come to healthcare system, again, depends on our problem, we may define our fairness metric differently. For example, suppose that I have built my AI model to be used in a clinic, and I want to make sure that they have correct disease diagnosis, and the diagnosis that they give per disease is something that's like very important for me. So in that case, I may focus to check how is the correct disease diagnosis in different subpopulation in my data set. In another scenario, suppose that I'm using my AI model just in a triage, for example. And in that scenario, it's not really important for me to know what's the disease of the patient, but what's important for me is that the patient shouldn't be underdiagnosed. So I don't want to flag a sick patient as healthy, because that patient may not visit a doctor and may receive a lower priority for visiting a doctor compared to the other patient which has been flagged as unhealthy. And we call it like underdiagnosis rate. And we want to make sure that we don't have like underdiagnosis rate in such system, because it will provide delay to access to get care for those patients. Another scenario would be even overdiagnosis. Like, overdiagnosis is also might be harmful for the patient. For example, in the algorithms that we are developing for detecting clinically significant prostate cancer, we are often suffering from high false positive rate. And and if a patient like call that that be like suspicious for having the cancer, they have to go over different procedures such as biopsy, which is very harmful and not convenient for them, and it's very hard for the patient, and they have to spend a lot of money, and overall these algorithms have very high false positive rates. So it's not something good, and we don't want that happen for the patient. So depend on the problem, really, like you need to define a specific fairness matrix. Now let's focus to our questions. So how is the fairness of AI chest X-ray pathology classifier? Are they fair or not? In order to answer this question, we look into like 3 large public chest X-ray data set that we are available. Mimic CXR, Chexpert, and NIH dataset. And we also kind of aggregate and make all these 3 data set on shared label and made a multi-source data, which we call it in this presentation all data set. So we have followed the standard approach in training AI models and try to optimize our performance average across all patients. And we reached to the state-of-the-art performance in all these 4 data sets. So that's a point that usually the researchers stop. They are like, they are like kind of saying, okay, this is our performance. Our model is doing very well. And that's a point that like, that's really a standard to stop. But what we think is that this is not a good stop point, and we better to have another step, which is fairness check. So for suppose that I wanted to check the correct disease diagnosis fairness on my model. In that scenario, I'm following the equality of opportunity notion of fairness, and I wanted to make sure that the true positive rate of the system, the AI model, is not changing very in different sexes, races, ages, and patients with different insurance type. Here, I'm using insurance type as a proxy for the social economic status of the patient, because, for example, the patient who are using Medicaid insurance are often low income. So we are defining our fairness matrix here. Suppose that I have a binary attribute such as sex, then the true positive rate disparity, I define it as a gap between the, for example, for the female patient, I would define it the true positive rate of female minus the true positive rate of male patient. And in that case, if those 2 groups have equal true positive rate disparity, then my gap would be 0, and that's my ideal situation. But if the system behaves in favor of the female, the true positive rate disparity would be positive. And if the system behaves like against like female patient, the true positive rate disparity would be negative. Now, if I have other like attributes which are not binary, for example, races, I define the gap as true positive rate. For example, for true positive rate disparity of Black patient, I would define it as true positive rate disparity of Black minus the median of all true positive rate disparities that I have in my system. That I have in my data set for different subpopulation, like true positive rate of White, Black, Hispanic, and other races that I have in my data set. Now, if all the true positive rate disparities be like around a same centroid, then I have 0 gap. But if the true positive rate of Black patient is below the centroid of the other true positive rate disparities, then my gap would be negative. And it shows that the system behaves against this subpopulation. So we have done this across all the disease labels that we had in this 4 data set, Mimic CXR, Chexpert, NIH, and the all data set. And we average the gap that we have between the, for example, most favorable subgroup, for example, for disease edema, suppose that patients who are using other insurance, they have higher true positive rate positive gap. And for example, patients with Medicaid insurance, they have the least negative gap. So the distance between this gap, this true positive rate disparities, we call it the gap between like true positive disparities per label. So we average these values across all our label, and show the average gap here in different attributes and in different data sets. Then we count how many times like the system behave in favor of like some subgroups or like against some other subgroups. Like if a group receive more negative gap often, then those groups are unfavorable subgroups. But if a subgroup receive often positive or zero gap, we call them favorable subgroups. And we see that female patient younger than 20 years old, Hispanic patient, and patient with Medicaid insurance who are often low income, they are often among the unfavorable subgroups across different data sets that we have done our study. And on the other hand, the other subpopulations such as male, the mid-age patient, white patient, and patient who are using other insurance, not Medicaid or Medicare, they are among the favorable subpopulation. So that's interesting because like the unfavorable subgroups are the one who are often among like historically underserved subpopulation. One other things that we can notice here is that when we have trained our model on a multi-source data set, that model has lower average gap compared to the like single source data set. So it seems that if we are training our model on a multi-source data or using the algorithms such as, for example, maybe if you use like algorithms that they are based on training on multi-source data, such as federated learning, maybe we can reduce the unfairness of the system. The other next step, we kind of try to check the fairness of our model with respect to underdiagnosis. So in that sense, we just look into the no finding label. And the reason that this label was very important for us was that false positive rate in no finding means that the patient has a disease, but the classifier flagged the patient as healthy so that the patient will not receive access to care in a timely manner. So we check the underdiagnosis rate in different subpopulation in our data set and check what's the distribution of false positive rate in no finding. And here you can see the underdiagnosis rate over different subpopulation of sexes, ages, races, and even social insurance type. And we can see again female patient younger than 20 years old, Black patient or Hispanic patient, or patient with Medicaid insurance, they are having higher underdiagnosis rate compared to the other patient in the data set. The next question that we had was that, okay, suppose that the system do not do like equally, the AI model do not behave like equally for all those subpopulation. Suppose that like if we just look into the female who were like underdiagnosed, are all female have kind of in the same plate and they are underdiagnosed in the same rate or not? That's why we have a study intersectional identity underdiagnosis to see in different intersectional identity, how is the distribution of my underdiagnosis rate? And as you can see here, the female who are, for example, Hispanic, or the female who are using Medicaid insurance, who are often low income, and the younger female, they are having higher underdiagnosis rate compared to the other subpopulation. Therefore, it seems that if a patient belongs to more than one underserved subpopulation, they may having higher underdiagnosis rate compared to the others. So one thing that we were wondering is that, okay, we have shown that there is a higher underdiagnosis rate like across some subpopulation, and those subpopulation are like the historically underserved subpopulation. But why do you call it systematic bias? Maybe it's just a noise in the system. So maybe that's happened just because you have noise in the system and your model is not doing well. So in order to see like if that's a noise in the system or it's a selective algorithmic bias, we check the false negative rate in no finding label, which is overdiagnosis rate. So if it was the overall noise on the system. At the same time, when we have higher false positive rate, for example, for a label called no finding, we should also have high false negative rate for that label as well, because because the model is not doing well. And you can see here the distribution of overdiagnosis rate over different subpopulation. And interestingly, we see that there is a reverse relationship between underdiagnosis rate and overdiagnosis rate. So underserved subpopulation are being flagged wrongly healthy without corresponding increase of wrongly diagnosed of disease by an algorithm. So we like this reverse relationship shows that us that that's a kind of it couldn't be an overall noise in your system. Then we check like all the other data set that we had and see like how is the distribution of most underdiagnosed group and, for example, least overdiagnosed group. And among different data set, Mimic6, Arch, Expert, NIH, and all data set, we kind of commonly see this inverse relationship. And the groups that they are experiencing the most underdiagnosis rate, they are the ones who are also receive the least overdiagnosis rate. So this result shows that like our result is kind of consistent across different data sets. So this higher underdiagnosis rate is not an overall noise in the system. When I'm talking to like people, especially those who are getting data set, like I heard someone was telling me that, for example, we don't have sex unfairness because we have an equal proportion of male and female patient in our data set. So we are fair and we are not worried about being unfair. So just to see if that's a correct statement or not, we check if there is a statistically significant correlation between subgroup disease membership, the percentage of people, for example, who are having edema, and for example, they are Black patient, and the percentage of white patient who are having the same disease, but they are from different subpopulation. We wanted to see if there is a correlation between the true positive rate disparities that they are experiencing and also their disease membership. And there was not often a statistically significant correlation between these two factors. And also later we did another study, like in Emory Hospital in US, they have access to a very unique data set, which I like it a lot because most of the data set that we are having, the public data sets such as NIH, such as Mimic6R, they are having higher white patients and the other like subpopulation are very smaller. For example, the white patient are 68% of the data set, and the second largest population after white patient are Black patient who are 70% of the data set, 17%. And then like the other races are very minority. So the unique things, interesting things about this Emory data set was that they have 50% Black patient and 50% white patient almost. And when we made a model on that data set, we see that the same pattern of biases that we are seeing in Mimic6R data set, which is very white skewed, exists also in the images that we are getting from Emory Hospital. So that might be another reason that like the percentage of patient that we have might not be that much playing a very like big role here. So equalizing the proportion of patients from different subpopulation in dataset does not provide fairness naturally, and it's not always even feasible. Suppose that you have a data set of like, if you just consider sex, yes, you might be able to do that. But like when you are considering different other attributes that you have in your data set, it's not really easy to do that. The other statement is that we don't have race unfairness because we haven't included race data in our AI model training. That's very like kind of interesting because, for example, in healthcare system in Canada, we are not gathering the race information of the patient to be fair. And now let's see if that approach provides fairness or not. Honestly, when we were just seeing like those underdiagnoses in the underserved patient, for example, in Black patient, and such a huge gap on the performance of the model between white and Black patient, we were wondering why this has happened. We talked to the radiologists in our team, and they were saying we even see the patient when we are going over the images. How can I be, as a doctor, unfair to a patient that I even haven't seen that patient and I don't know what's their kind of race? So we said, okay, let's check if AI model can detect the patient race from medical images. And surprisingly, across different data sets and across different medical image modality, we were able to find the race of the patient by just feeding the network the medical image of the patient without any demographic information. And that was consistent across different data sets with a very high performance. So it seems that AI model can detect the race of the patient from medical images, though the radiologists are not able to do that. So, not including demographic features such as race or ethnicity do not impose fairness in your model. Now, I want to have a very short discussion about like why these kind of things might be happening and is there like some potential solutions or not. So, the reality is that the label that we are using for training these models, they are not kind of like golden labels. Like these labels are coming from clinical notes that doctors have written. And we have already seen that bias and unfairness exist in like AI model exists in healthcare system without using any AI model. Like that's not a problem that AI bring to the table because AI is not fair. Like before using any AI, like the unfairness was existing in healthcare system, and we have a lot of literature that have gone through that. So kind of AI do bias amplification, and because it is training on a data which is already unfair. The other things is that we are using NLP techniques to labeling these medical images, and like these NLP techniques and the fairness of those NLP techniques is also questionable, and they might be the underlying source of biases that kind of reflect itself on the results that we are getting. And overall, that's why we are thinking that disparities probably originated in the data, regardless of the AI algorithms that we are using. In the underdiagnosis bias study that we use, we just use a single model, like a DenseNet model for training our AI model. But in another study, which was race detection, we use like different models, and like regardless of the model that we were using, we were able to find the race of the patient. So the problem is most likely in the data rather than in the algorithm. So some people tell me, okay, you have used like fixed threshold for like all patient in your data set. And one kind of, and the threshold that I was using was trying to kind of maximize the F1 score across all patients. That was the kind of a standard approach that in other paper they were following when they wanted to report their results. But yeah, you are free. You can use different threshold for different patient that different like groups of patient that you have in your data set. But this kind of method require you to know the patient membership to different subpopulation. And there is always uncertainty in this definition, like the definition of the race and ethnicity of the patients. It's not something very clear. Like And the boundaries are often, in some cases, are very unclear, and they are depends on, for example, social construct and things like that. For example, I, as an Eastern female, it's whenever they put me like a questionnaire, like to check mark your race, I really have hard time because I'm not Hispanic. I cannot like find myself in like the groups that they are writing over, which are like white, black, Hispanic, Asian. And it's really hard to kind of force people to put themselves like in this member, in this subpopulation, and define their kind of self-reported race. So it's not something very convenient for every subpopulation that we may have. The other things is that the number of thresholds that you are going to use will grow exponentially with the number of protected attributes that you have. For example, it's not just race, it's not just the sex. It might be some other factors that you may not do, may want to consider to do fairness analysis, and we cannot consider like thousands of like threshold for each patient, and that may also even provide unfairness. So why lack of fairness in AI diagnostic is crucial? Just to summarize, like we kind of shows that AI model not only can detect the patient race from medical images, but also behave against historically underserved races. And you can imagine when like this code came out, that's something that people kind of get panicked. So we can see like such as this reaction that who will save us from a racist AI? And we don't want that. So solving these kind of issues before kind of moving these models to practice is very crucial. And this is very critical barriers to effective deployment of this model in practice. So if I wanted to kind of have it just one take-home message from all this presentation is that we really need to encourage clinical decision makers to carefully audit for fairness prior to deployment of their model. And fairness checks should be part of the pipeline of like like saying that like this algorithm is doing well or not. And if we are showing a very good performance average across all patients, it doesn't mean that this algorithm is doing well for all subpopulation in your data set. And we show that the algorithm may do very well average across all patients, but it may do much better for some subpopulation and much worse for some others. So I want to thank you, my research collaborators on these studies, and also the funding agencies that provide us funding for this research. And thank you for your attention.